story called Ajolotl by Julio Cortázar, who is a really amazing Argentinian writer who lived most of his life actually in political exile in Paris. So anyway, this story, so Julio Cortázar writes stories that are incredibly surreal. Things happen in his stories that you cannot begin to predict or imagine or sometimes even understand. In this short story, the protagonist is obsessed with this ajolotl, with this little creature, this swimming salamander. And every day he goes to the botanical gardens, the aquarium in the botanical gardens in Paris. They're really there. I got to visit them myself. The character is obsessed with the ajolotl and just stares and stares and stares. And I'm going to read you a little piece of the story, first in Spanish, and then I'll give it to you in English. Mi cara estaba pegada al vidrio del acuario. Mis ojos trataban una vez más de penetrar el misterio de esos ojos de oro sin iris y sin pupila. Yo veía de muy cerca la cara de un ajolotl inmóvil junto al vidrio. Sin transición, sin sorpresa, yo vi mi cara contra el vidrio. En vez del ajolotl, yo vi mi cara contra el vidrio. La vi fuera del acuario. La vi del otro lado del vidrio. Entonces mi cara se apartó y yo comprendí. My face was pushed up hard against the glass of the aquarium, and my eyes were trying again and again to penetrate the mystery of those eyes, those golden eyes with neither iris nor pupil. I saw from very close up the face of an ajolotl frozen, unmoving against the glass. Without transition and without surprise, I saw my face against the glass. Instead of the ajolotl, I saw my face against the glass. I saw it outside of the aquarium. I saw it on the other glass. And then my face moved away. And I understood. So powerful, right? Of this amazing, unexpected transition, becoming this thing that you're obsessed with. Both are being transformed in this relationship, although in very dramatic and unexpected ways. But this has been a really important framework for me. I'm constantly thinking in my work with patients and with my learners. Like, when I look at a patient, who am I really seeing? Am I really able to see them for all that they are? Is my vision of them obscured by the reflection in the glass? How clear is my side of the glass, and what work have I done to be able to see clearly? And what about transformation? How are they changing? How am I assisting in their changing? To what degree do I put myself into their shoes, literally into their ajolotl skin? And what happens to me in the process of transformation as well as the quote-unquote healer? It turns out that this friend of mine as a kid gave me this story in English. I was maybe 13, 14. I loved this story. It spoke to me. It sent me on this trajectory that I decided I wanted to learn Spanish so I could read it in the original. And that put me on a whole other trajectory, a professional trajectory of, I got this idea, this other vision, this calling that I wanted to be a Spanish-speaking psychologist. I'd grown up in LA. I knew about the unmet need. I felt like that was something that I could do. So started studying Spanish, and fortunately Spanish for me in high school and in college. I have to tell you that when I was at UC Berkeley in the Spanish department, a visiting professor came for a semester, and it was Julio Cortázar. I feel like full of emotion as I tell you this. This was very powerful and important to be able to learn from him and study with him, and to sort of talk with him a little bit about my dreams, right, about a career path and his influence. when I went to graduate school in Boston, I set my goal to become a bilingual psychologist. And so, my first clinical placements were with kids. We all agreed that might be the best place to start with my Spanish. Anyway, my Spanish language was coming along quite well, but I learned very quickly that language alone was not going to do the trick. I really needed to understand so much more about culture and history and immigration and economics and spirituality and religion and roles and gender roles and so forth. I needed to understand so much more about families. And in my internship and postdoc at UC San Francisco, I really was so able to immerse myself in exquisite learning about all of those things. Later, when I had my first job as a faculty member at CSPP in Los Angeles at Alliant, I learned what I did not yet know, which was that there was a lot more to learn also for me about power and privilege and racism and oppression and all of those dynamics and the play of those pressures on one's health and mental health and well-being and family ties and so many other things. So this has really been a little bit about what my journey has been, and it's all led me so perfectly to the job that I have now. So we sort of talked a little bit about these great foundations I've had in my grad school, my internship. I did a fellowship in Madrid for 2 years, and that was very exquisite, a lot of fun. But at a certain point, it was time to come back, right? I came back to the States. I got that job at CSPP as a white male faculty member in the multicultural track. And lots of people were asking me a lot of questions. What are you doing here? Why are you in this field? And I had to find a way to really articulate what my role is and what I intended to do and what I wanted to teach and the work I wanted to do. I was doing some clinical work 1 day a week at a community mental health center in East LA, and all the practitioners went to lunch, and one practitioner, one psychologist said to another across the table, "Hey, I heard this really cool job where you teach physicians about doctor-patient communication." And the woman said, "I'm not interested in that. I'm about to have a baby, and I'm not moving." And I raised my hand and said, "I'm really interested in that." And I went back to my office and I sent my resume and had an interview, and this came into my lap, this brand new job where now I'm the director of behavioral sciences in a family medicine residency. So we have residents spending 3 years after medical school learning to be healers, right, in a program focused on the underserved community in East LA. And I will tell you, I was terrified. I was out of my league. I didn't know that otitis media is an ear infection. I didn't know the whole language or culture of medicine, but I decided that I was going to go really slow, and I would find mentors. Dr. Zamudio, Tony Zamudio at California Medical Center just down the street in downtown LA was one of those very precious mentors. And I just went slow and steady. And I decided, because I had read this book by Sue and Sue about cultural, counseling the culturally, I can't remember the title, I'm so sorry. But in there they talked about how in culturally responsive mental health intervention, it's as if we're giving gifts to our patients. And that's the approach I've taken in my job. I decided that I was going to give gifts to all of these medical residents and to my medical colleagues, gifts from the field of psychology, gifts about diagnosis and intervention, gifts about positive psychology and well-being, gifts about communication and feedback and behavior change. And the more I was facing clinical and learning challenges with my patients and colleagues here, the more I was able to draw from this powerfully rich field of psychology to bring these gifts to people. So I've been at White Memorial now for just about 19 years, and I do lots and lots and lots of things in the course of my day, my week. and I want to tell you about some of those things. All right, my office is the largest office here in a primary care clinic, which is pretty amazing and interesting. I don't need a large office to do the work that I do, but I have the largest office. And not only that, if you were in my clinic, you would see that every patient walks past my office when they are brought in from the waiting room to be, for their weight and pressure and so forth. They walk right past my office, and so they see the sign on my door that says, Jeff Ring, psychologist. This is really wild. This is not a mental health clinic where I work. This is a medical clinic. This is where you come to see your family physician. And yet, psychology has a very big presence here. I feel like that's what this room and my placement of my room are saying. Every patient that comes through gets the message that you're welcome here with your medical problems and your psychological problems as well. And we will work arm in arm in an integrated model to really treat you in a holistic way. So, so my office, I think, says a lot. I work with 21 family medicine residents, So there are 21 residents, 7 per year, and then we're constantly rotating every July 1st. So June 30th, 7 graduate, and July 1st, 7 more begin. That was a transition for me. I used to work at an academic program where people graduated in May, and then we would find a beach or something in the summer, and then school starts again in the fall. That's not how it works here in the medical model. It is overnight turnover. It's really fast. So I've had to learn a lot of things about medical culture and about the timeline and how quickly things go. And I've had to really up my own velocity in the work that I do. So I work with these 21 residents in many different ways, which I'll tell you more about. And I work with faculty. I'm one of maybe 14 faculty members, all family doctors, except for I also have one social work colleague who's also on my team of behavioral sciences. So patients come to the clinic to see their doctor, and it's family medicine, so it's from newborns to the oldest of old. And as I teach residents to sort of heighten their radar for psychological or family issues, they can call on me or Emma, my social work colleague, to work with them right on the spot. So, for example, recently a resident was seeing a patient weeping and weeping because she had a fetal demise, right? Her pregnancy ended before she was ready to deliver. And so the patient is a wreck, and the resident is pretty much a wreck too. And she's asking lots and lots of questions. So he just grabbed me, and we went in together. We closed the door. We just sat down, and we listened to her. We witnessed. We sat with her, and we answered her questions. She had lots of questions. Was it because I reached up? Was it because I bent over? She was doing a lot of beating herself up. She was doing a lot of sort of really just grief, right? Just in the throes of terrible grief. And so I was able, I think, to be an anchor in some ways for the patient and for the physician as well. Just because you go to medical school and residency training doesn't mean that you have all of a sudden this magic ability to sit with that degree of trauma and sadness and loss. So that's part of my job as well, is to role model and to support the resident. We sat with the patient. We scheduled a follow-up counseling visit with her later that week that I was able to see her. And at the end of the day, the resident came into my office, and we closed the door, and he just wept. I just held him and contributed, I hope, to his own very human navigation of what is such a treacherous journey in medical education. But I have to tell you, this work is so exquisitely gratifying. It's gratifying. It's gratifying that I was able to be there in a linguistically and culturally relevant way for this woman, and to be there in a nurturing and supportive an educational way for this resident. Amazingly gratifying. And right, so that's one of, I have 19 years of stories, lots of stories of how perfect it is, how beautiful, how right it is to have a mental health practitioner, a psychologist in a family medicine clinic. So, the world is now talking about patient-centered medical homes and patient-centered care and integrated care, and there are elements, thank goodness, in, the Accountable Care Act and so forth. But we've been doing that work here for 25 years. I've been here 19 of those, and it makes perfect sense. The good news is that there are so many more opening opportunities now for psychologists to do this work. I mean, the time is just ripe, and there's so many more resources. The American Psychological Association has put together and is working so hard for specific training guidelines for psychologists to work in primary care. When I started, we were kind of on our own, except I had, some informal colleague supports. So anyway, going back, so I'm here to work with the residents on site as they see patients, and the range of cases that they will grab me for is amazing, right? A lot of them are the ones that they can't stand that I really love, like the sullen adolescent who won't talk or answer their questions, or the elderly patient who is not taking their medications or following their diabetic diet. Or sometimes it's making a child abuse or domestic violence report. For all of those cases, I can walk arm in arm with them. I can support them, I can show them, I can teach them so that they hopefully will be more empowered to be able to do that work next time, right? That's part of what medical education and residency training is all about. We also do co-counseling here. So the residency's patient and we had, for example, one I saw yesterday, a patient who's taking way too many pain medications, and we're trying to do a pain contract and really try and help find other ways to manage his pain, except these very dangerous and addicting medications. So we schedule 45 minutes for me, the patient, and the doctor together. We work as a team. We work collaboratively. And the residents aren't always here in clinic, so that patient showed up last week asking for more pain meds. Unfortunately, since we've done such good teamwork, we were able to pull out his pain medication contract, and we were able to see, yes, it had been 30 days, and he was entitled to more meds. And so, it's good quality care. It's care that is with continuity and respect, and it's, I think, richer because there's sort of a multidisciplinary approach. So, let's see. All right, so there are these behavioral sciences education core principles. These come from the Society, let me just type it in. The Society of Teachers of Family Medicine, and so that's it. STF. This is a really important organization for me, has been very important in my career development. So these are all people who teach family medicine, medical students, and residents across the country. It's an organization of teachers. It's an organization of people who are looking at the best ways to bring optimal training to residents. And within this group, there are all of us, the behavioral science faculty. We have a group on families and families and behavioral medicine, and this is my group of mentors and peers. This is where we really put our heads together to optimize the training that we deliver with creativity and with effectiveness. So that group has put together these core principles of what our job is about. So I wanted to just go over those, and with each of them I wanted to give you a little bit of an example about how I breathe life into these in the course of my work, if that makes sense. So the first one is to implement biopsychosocial and relationship-centered approaches to care. And that's what we do. let me say something about this. I feel powerfully empowered to do my work. The director of this residency has such strong confidence and support for my work, so welcoming, so engaged, that I feel confident. I'm not intimidated and I'm not scared. I also have a list from our accreditation agency, the ACGME, the Accreditation of Graduate Medical Education for all residencies, that says all residents must learn these things in behavioral sciences. For our lifeline, we have to be teaching these things. So I'm not ever shy to teach them. I look for every opportunity I have to teach them. I don't really face much resistance from the residents. It's pretty rare. I nurture collaborative relationships with them from the very beginning. But if I did, I'm not shy to teach them because this is important. This is what doctors need to do. This is, I believe, and ACGME believes, makes an optimal healer someone who has good, strong communication skills and can work effectively with patients in a biopsychosocial context, can learn to negotiate treatment plans with patients that take into account the patient's worldview, take into account the patient's own health practices and spiritual beliefs. So I feel very confident in my capacity to do this work. And over the years, even more so, when I speak to internal medicine or OBGYN or other groups that aren't as psychology friendly as family medicine, there too I'm not shy. I found my voice. I feel like OBGYN and internal medicine doctors also, for optimal care, need to be attentive to the doctor-patient relationship and communication and patients in a psychosocial cultural context. So I'll say one more thing about this. That is that, psychology and psychiatry have not always gotten along so well. There have been turf issues. Psychiatrists and family docs also tend sometimes not to get along so well. But family medicine and psychology, it's exquisite. And my colleagues that do this work in residencies across the land and in medical schools pretty consistently are able to report that we have found a very warm and accepting home, a place where we can bring the best of what we know in a collaborative way. I am so grateful when residents come to me asking for information or support. I am so grateful when my residency director is asking questions or needs help or support. This is a great role to be able to fill and to fulfill. And like I said, very, very powerfully gratifying. So anyway, one way that we teach relationship-centered approaches to care is we have these, I'm doing one this Friday afternoon, we have standardized patients. We have actors who come through playing different kinds of patients, and the residents come through and have different tasks. The patient that I will be observing this week is a woman who will be playing a role of the doctor has to give her end of life, delivering bad news at the end of life, that her cancer is untreatable. So this is a way that we're able to watch, assess, and also provide feedback to our residents in a kind of a controlled, standardized way. It's also a really wonderful way, I think, to be able to work with the residents, to be right up close and watching how they do. And the last group did really poorly, and so we've been spending a lot of time teaching some basic things that probably you know, right? Like silence is okay, and that empathic response is really important, and not knowing is okay, things like that. So anyway, we implement biopsychosocial and relationship-centered approaches to care. And this is both here in the clinic and in the hospital, where I work with residents on having family meetings and also delivering news or bad news, or keeping families informed of a patient's progress, dealing with conflict, right? Dealing with intense emotion, dealing with grief, dealing with loss. It's really a lot. The second one is promote patient self-efficacy and behavior change as primary factors in health promotion and disease prevention. Behavior change is exquisitely important. You may have been hearing lately about this new movement of patient activation. This is also part of Obamacare, right? That patients are more engaged and active in their own health and self-care and well-being and active in relationship with their physicians. So one of the ways, one of the gifts, right, of, let me just type it in. One of the gifts of psychology is motivational interviewing, a way of helping people change their behavior, a way that's been empirically shown to be much more effective than advice giving, a way that physicians can learn some pieces of this and do it effectively in the context of brief medical visits with patients. So I do a lot of motivational interviewing and teaching, some formal lectures, as well as when they are on a rotation with me, we spend some more intensive time learning about and practicing and filling their bag, their tool bag, with lots of motivational interviewing tools for working with their patients. Let me just say a word about that now. I work with the residents in lots of different ways. One way I just mentioned is that they have specific time that we spend together on rotations for behavioral science issues. There's also a science rotation in their third year, which is really amazing and gratifying experience where it's really about physician well-being. We spend 3 full days away from the hospital, out in the community, out around Los Angeles, and we just go to places that they like or that appeal to them. And in those places, gardens, beach, a museum, we talk about their life. 3 full days. What was their calling? Why did they want to be a healer? What was it like to go through medical school? What was the sacrifice? Did you doubt yourself? Did you suffer? Well, how did you get to residency? How did you choose family medicine? How is it going now? How are you doing as you wind down your training? And what do you see into the future? What values and priorities are important to you? How will you deal with your a new income, an increased income? How are you going to deal with debts? How are you going to balance work and life as you go forward after having had such little balance for all of these years of sacrifice? So again, really amazing, different way to work with these residents. It's a personal empowerment way. It's a relational way. It's a well-being way of being together. I work with residents. I do a monthly behavioral science lecture on all these different themes: depression, anxiety, child abuse, motivational interviewing, positive psychology. I do monthly interviews on culturally responsive healthcare, how we eliminate health inequities, how we understand health disparity data, how we negotiate care, how we help them look and explore their own biases and stereotypes and comfort zones. We find a way to provide exquisite care to every patient, even if it's a patient that you don't understand, that you don't like, that you disagree with, a patient that's making life choices that are completely opposite from your own that you would make for you. Every one of those patients still deserves exquisite care. And so we have a specific lecture series designed to do that, as well as the opportunity to sort of work with them ongoing. Every patient that a resident sees is presented to a preceptor, one of the medical faculty in the back. And very often I will sit with them and co-precept, co-teach them about the psychological issues. And I do that at times as well for the inpatient team, as they're working with hospitalized patients as well. Every year I run a faculty resident retreat. It's dedicated to team building and well-being and usually I draw from the humanities and from arts and doing all kinds of different playful, creative activities together. As the lone psychologist, I think that I have a lot of latitude. I can really bring in the softer side, the humanistic side, the literary and artistic side of doctoring. And I feel like that's an important voice that doesn't always come through in traditional medical education. So that's fun. Those are things that I love, and so I'm happy to bring them to the work that I do as well. I also spend a lot of time with people at the beginning when they first arrive. We have an entire month of orientation, and that's a time when we do a lot of team building. It's a time when we help them get to know each other, get to know the other residents and faculty. It's a time where we let them assist them in getting to know this community of Boyle Heights and East Los, getting to know where our patients work and live. We have lots of experiential exercises and activities out and about. And it's also a time where we look at Myers-Briggs profiles, right? So they can start to learn about each other's sort of personality strengths and tendencies. And it's a time really for trying to bolster their own time management and well-being and self-care plan as they then begin to move forward in several years of what will be exhausting, emotionally and physically exhausting work. All right, let's keep moving forward here. The third one is integrate mental health and substance abuse care into primary health. And I think we've talked about that, right? We do co-counseling. I work with them and their patients on these issues. Let's see, some integrate psychological and behavioral knowledge into the care of physical symptoms and diseases. So it's not just helping them identify and treat psychological issues, but it's helping them really empower their patients, say with diabetes, to begin to think about different ways of eating, checking their own blood sugars, perhaps navigating depression, if that's a part of the picture as well. Let's see, promote the integration of sociocultural factors within the organization and delivery of healthcare services. This has always been something that's been important to me, right, along this whole professional trajectory. We were very lucky to have to receive a grant from endowment, which gave us resources to really put in place our cultural medicine curriculum. At the end of that grant, we wrote it all up and we sent it off to the California Endowment, and I said to my residency co-director, you know, this is a really great document. It shouldn't just sit dusty on the shelves of the California Endowment. This is something worth disseminating. And he gave me a green light, and I found a publisher, and we pitched it. And this book got published in, I think, 2009, the Curriculum for Culturally Responsive Healthcare, Step-by-Step Guide for Cultural Competence Training. I just want to say a word about this in terms of my career development. Having published this book, which not that many people have read. I know my aunt has a copy, my dad, but actually, you know, it's dedicated to a very small group. But I think for this group, in medical school educators and residency educators, it's a very helpful set of curricula. But this has been rocket fuel for my career. So just bookmark that to find an area that is your area and to write it down and to disseminate it and share it with others brings amazing opportunities. I have huge opportunities now for consultation and teaching and travel. I've just been invited to the Middle East. I'm going to Qatar in a few weeks to work with the Ministry of Health and to work with the medical school and to really try and enhance their culturally responsive healthcare to a nation of many international workers. Yet a country that has, you know, a lot of very important and strong religious and spiritual beliefs about health and doctor-patient relationships. So it's going to be a really cool challenge. So anyway, bookmark that. When you know what you know and you're confident in what you know, it's really important to write it down and to disseminate it. It makes a big difference on our career trajectory. So that's demonstrating the importance to health of family, social, cultural, spiritual, environmental contexts. We also, during that orientation time, I asked our new 7 interns to do a 1-hour presentation of their own family, their own genogram. They tell their own story of who they are and on whose shoulders they have sort of ridden in on. And it's powerful. It's a powerful way for us to get to know them. It's a powerful way for them to build team connections. It's a powerful way for them to begin to develop skills of self-reflection, which is very important, I think, for anyone in life, but particularly if you're a professional, particularly if you're in a profession where mistakes are made, and one has to be, sort of ever vigilant to our own competency and well-being and self-care. It also teaches them about how to do a genogram. So when they meet patients, they can begin to think again about patients in the context of their family. They can understand who this person is in a greater context. We practice a developmental and life cycle perspective with learners and clients. So I've had to learn a lot, right? I've had to learn a lot about human development and refresh all of that. I have to learn about newborns, and I have to learn about geriatric patients. And I'm part of a geriatric assessment team where every Friday I go do a home visit with a resident where we assess elderly patients in their home. We learn about their whole life story. We learn about where they grew up and if there was an immigration history. We learn about their current living situation and socioeconomic status. We see how they're sleeping and eating. We check their refrigerator. We roll up carpets that can be tripping hazards. We talk to them about their mood and spirituality, if they're suicidal. We talk with them about, assess their mental status. And that is one of 3 assessments. They also have some head-to-tail medical, physical exams as well. And then as a team, together we work on recommendations for how to keep this person safe and healthy and in their home as long as possible. It's really gratifying, amazing, delicious work. And again, the voice of psychology in running those family meetings, when we give the feedback, in being in those discussions, is exquisite and essential. I mean, once you've been in this integrated model, everything else really looks suboptimal to me, I have to say. Encourage and support the providers. That's probably the part of the work that I love the most, right? I bring my counseling skills and nurturance skills to empowering them. The residents know that my door is open and they can find me when they need to talk. And we also have this program where when a patient dies in the hospital, the chief resident will call me and let me know who was working with that patient. And I'll go find them in the hospital and I'll check in with them. How are you doing? Sometimes it's a patient that was a code in the middle of the night. They didn't know the patient. It's bad, but not so bad. But sometimes it's a patient they were working so closely with, fighting for. They were part of the family. So I find them and check in with them and sit with them in that tragedy and see how they're doing. That's really important because we don't want to only train excellent physicians. We want to train excellent physicians with a long shelf life who leave here knowing how to take care of themselves and how to find the best balance between work and life. And this work of healing, psychology, medicine, even more maybe, it's really intense. It's a lot of responsibility. It's a lot of details to keep an eye on. It's a lot of paperwork and computer hassle. It's intense. So I find it most gratifying to find ways to support them. A colleague and I developed something called HNH, Healing and Hopefulness. We did it just yesterday. Every month we have a noon lecture which is called M&M, Morbidity and Mortality, which you can see it sounds so miserable. These are cases that went really wrong. These are cases where, patients died or wrong diagnoses or the wrong medicine or errors. And it's important. We have to learn from these cases, even though it's very bleak and very stressful and very hard. So we've tagged on something at the end of those sessions called Healing and Hopefulness. It's a chance for everyone in the room to talk for a few minutes about what has been going well in the last month. What have they really appreciated in their work for patients? What has been gratifying and meaningful? What have been the heroics that they have seen in the colleagues? Lots of expression of appreciation, lots of expression of patients that unexpectedly got better. Or someone said yesterday when she went to do the mental status exam and asked the patient to write a sentence, the patient wrote, "I love Dr. X," right? Her name. So beautiful. So people have an opportunity to share, and we all have an opportunity to listen. This is right out of positive psychology, right? This is the balance. This is really important to be talking about and remembering why they're on this treacherous journey. What is going well? Finally, self-awareness, empathy, and well-being, all square from the field of psychology, right? I'm always working with them, giving them readings, asking them what they thought about that, having them write dialogues with themselves about their own ageism, helping them develop professionalism and empathy, sensitivity. I go in the room and observe them in doctor-patient encounters and give them very detailed, specific feedback about what I saw, their strengths, and areas where they need, I think, to really stretch themselves. We do a lot of narrative writing through journals and portfolios, and I collect their writing, and I keep it just like a kindergarten teacher would collect kindergarten artwork in a file, and we go over those at the end of each year. Reflections, where are they now in thinking about important issues related to doctoring? Okay, so let me kind of wind down and then we'll open up for larger conversation. I just want to talk about some of the resources that have helped me along the way and helped me continually to do my work. It was the Society of Teachers of Family Medicine that I mentioned, and you can Google if you're interested, their group on behavioral sciences. Or it has a new name, which I can't quite remember. It's like Family, Group on Family and Systems, and I'm not sure, but I think you'd be able to find that. APA Division 34, I got the number wrong, it's 38, which is health psychology, and 45, amazing listserv, so many resources, so many colleagues that are doing incredible work. You know, I am not the psychologist I am without these APA colleagues and these divisions who have nurtured me as a graduate student and continue to nurture me as a grown-up, and for whom it is a delight and a pleasure to serve back, being on the board and or like today, being able to talk with all of you. I did 2 years of Jungian training. That was really important. I had to stop because I have little children and I just couldn't quite finish it, and maybe someday I could get back. But so important to be able to bring a depth perspective, to be able to think symbolically, to be able to provide a richness of care. You know, my clinical work is very eclectic. I can bring on cognitive behavioral. I can bring on motivational interviewing. But a lot of what I do is good old-fashioned Rogerian. But I'll work dreams, whatever. It's patient-centered. Where the patient is, that's the work that we do. I had a year, I think, of somatic experiencing training. Very important. I learned a lot about neurophysiology. If you don't know about this model, it's really interesting. It's just about using imagery exercises to reset someone's nervous system, you might say, after trauma. And the population with which I work is so traumatized in so many ways that that's been a very powerful adjunct to the clinical work and the teaching that I do. The Collaborative Family Healthcare Association, also excellent resources, good to know about. They have an annual conference. I'll give you a picture there of Bellar's book on clinical health psychology in medical settings. I haven't read the second edition, but I read the first edition when I started my job, and it was very, very helpful. And then I just want to say something about personal counseling. You know, I saw a Jungian analyst for many, many years, and while it helped in many, many ways in my personal life, it helped in many, many ways in my professional life. I have a feeling that that's really the meat on the bone of our professional development as psychologists. We have to write our papers, and we have to read our books, and we have to do our research, and we have to do all of that. But we really have to be working on ourselves to come to a place of voice and confidence and clarity, right? Is it the axolotl or is it me? Am I changing and transforming? And do I know about that experience, and do I know the struggles of that experience? It's also really important because it's self-care. And I have to say, I don't know how psychology training programs are doing nowadays, but when I was at Boston University, not once in my years there did anyone ever say, take care of yourself. How are you doing? How did this patient impact you? Maybe a little bit in supervision as I think about it. But with our residents here, we do a ton of self-care. We have well-being meetings. We go on hikes. We have these one-on-one conversations. Personal well-being of the healer, caring for the caregiver is so essential. So I really want to invite you in your very full and busy lives to be sure that you find a place for that. I think it's really, really essential. And I'm hopeful maybe you'll tell me that psychology graduate schools, a place where we should really be talking about these things, that we are having, that you're having those conversations and those sources of support in your work. So I know that's so much stuff. I've been jabbing for a long time, but I wanted to just give you kind of a great overview of this very complex and very cool work that I do. But I'm so happy now to hear from you, hear your thoughts, your reflections, answer questions, anything else that might be of use to you on your journey of education and toward your professional goals.
Attendees, well, Dr. Ring, thank you very much for that. Very, very, very informative talk. But attendees, if you can type in your questions in the text box, there's a little chat box. You can type in your questions there, and Dr. Ring, if you can kind of answer them as they come in.
You bet. With pleasure.
All right.
And we excuse me, musical interlude.
Yeah, it looks like a bunch of people are typing in, and that's great.
Yeah.
Just don't be shy, people. Just you can type in your questions, and we'll go down the list and let Dr. Ring kind of address a couple of them. We're good on time.
All right, good. Here we go. The questions are coming through. All right, so we'll start with Jill. I'm interested in getting into the integrated care work. What suggestions do you have in terms of starting, networking, and finding connections? I live in San Diego. Well, you know what? That's all right. So let me try and answer that. Let's see. I think that first of all, joining. Okay, first I would join the listserv of the Health Psychology Division of APA. I think that that's a really important place to begin. I'm not sure, Jill, where you are in your training, but certainly I would try and seek supervision opportunities in and around where you live in health psychology. Let me just tell you about this colleague of mine. This guy is brilliant. He's a psychologist in Pasadena, and he just went to a local hospital. You know, he was already licensed, he was already practicing, but he went to the local hospital and said, you know, I want to provide some support for your cancer unit. I want to provide some support for your cancer patients, maybe for the colleagues. You know, he thought that he would be able to really do some work with patients there and maybe get some referrals for his practice in Pasadena as well. Well, he did really amazing work. His work was very helpful to the oncologists and to the medical teams in the hospital. And he went to the hospital directors and said, you know what, this cancer program is terrible. You have no mental health services for your oncology patients. He said, why don't you see if you can find benefactors, maybe who are ex-cancer patients, who would be willing to fund better mental health services in the hospital for these patients or for the outpatients. And sure enough, the hospital went to some wealthy ex-patients who gave a ton of money to now provide mental health services to cancer patients at this hospital. And he now is the psychologist who provides those. So any patient that has had cancer that calls him for mental health services, whether they have insurance or not, or money or not, he's able to say, I'm happy to make an appointment with you. And he will just bills this foundation who pays him for the services. So he has done something brilliant. He's created as well as a funding stream for his own practice. I like that kind of thinking outside of the box. I think it's about networking. I think it's a lot about going to integrated care conferences. It might be finding out about what in San Diego, right, there's internal medicine and family medicine training programs. I would find out about, can you maybe observe on inpatient rounds? Can you sit in the preceptor's, room and get an okay to observe as residents are talking about cases? I think that there may be some really good ways to, if you can find the boldness in you, right, to reach out. I don't think I know anyone in particular in San Diego, but this kind of question I have seen on the health psychology listserv sometimes. I'm a graduate student. I'm interested in this area. I live in San Diego. Does anyone have any resources or contacts I might be able to reach out to talk more about it? I have to say, when students call me and they say, I want to just learn more about what you do, I'm always so happy to find time to talk with them and tell them. And I think most practitioners are really willing to do that. So I hope I've answered that, Jill, kind of in an incomplete way, but pitch me another question if I haven't. A good book, says Julie, on self-care is Trauma Stewardship. Thank you. I don't know that. I will make note of that. Thank you. Devin, what's my familiarity with internship? Okay, here it is. Internship and or postdoc programs offer integrated primary care tracks. I know there are a few out there, but would love to hear your impressions, what I should look for. Okay. Devin, one thing I'm going to ask you to do is to go to the Division 38 Health Psychology website and look through recent listserv posts, because this is an issue that comes up pretty regularly. There's one at UMass Medical, Alexander Blount, B-L-O-U-N-T, I believe, if you Google him. But there are very few. This is all on the cutting edge. This is really new. I think that many of us learn how to do this once we get our first job. So there's good news and bad news. The bad news is you may not learn how to do this until you have to do it. But the good news is once you have your job in primary care, there's like a fellowship within the Society of Teachers of Family Medicine for new behavioral scientists, which is exquisite. So what you really need is a good basic foundation in patient care. I think getting supervision and support in, good cognitive behavioral skills, good psychodynamic skills, good self-awareness of countertransference, good ability to communicate with others, reading and learning about human physiology, learning and reading about, what are the array of cases that patients see in primary care. I think that those are all really important. So even if you can't find the integrated care training right now, get a good, strong foundation in your psychology training, in your mind-body medicine training. Maybe look at things like somatic experiencing or EMDR or other very rich tools that you would be able to bring to a primary care setting. to be able to, when it's time to apply for a job, say, yes, I know EMDR and I know motivational interviewing, and I took a basic course in human physiology and psychopharmacology. I think those are all things that will be very impressive, right? And teaching. Well, I mean, if it's a teaching job, having teaching experience as well, I think is all really important. So I hope that was helpful. Susan, I'm a first-year master's in counseling at Esther in Seattle. I'm excited to share that our first core competency is, hey, care and development of the self. It's integrated into all our coursework. Oh, well, my pleasure. And I'm so happy to hear that, Susan. That's really good. Take it seriously. My work is intense. It's I get here in the morning and I just run all day. With every day is different, and the things that I do are wild and unexpected. There are crises and there are continuities. But when I get home, I roll around on the floor with my kids and my dog, and I get in the hills, and I swim, and I do my yoga, and have my spiritual life and my relationship. I'm very clear that I need to be focused on that in the evening so that I can come back the next day fresh and renewed. Thank you, Susan. And what are the best ways to present practicum training experiences to demonstrate one's competency and interest in working with an integrated healthcare paradigm? What are the best ways to present practicum training experiences? To present. I'm not sure exactly what you're asking, like present to a job interviewer, or but let me I'll try and answer, and then if I don't, ask me again. I think that you want to have your radar up for health issues with your psychology patients and psychological issues with your health patients. So you see a patient for depression and they have diabetes, read everything you can about diabetes and then diabetes and depression so that you know both ends. And then the next patient you see that has depression or anxiety, you want to begin to ask, well, tell me about your health. My work is consistently holistic. I never just work on one end or the other. I'm curious about patients as a whole, inside them, mind and body, their stress level, their immune function. And I'm interested then in, what about their psychosocial, family, economic, safety of their neighborhood levels as well. So I think, Donala, you want to be very curious, and you want every patient to be an opportunity to learn some more. I think that when you work with supervisors, you let them know what you're hungry to learn. You show them that you've done extra reading and work. Like, don't be sort of shy about that. Be curious, and then answer your own questions, and then let them know what you've discovered along the way. I think that is, I think that's good for your learning. It's certainly good for getting a strong letter, right, from your supervisors about your intellectual hunger and curiosity. And it's a good way to, I think, get a little bit more of your feet in both the body and the mind pools. All right, Nick. What's been your experience of medical patients rejecting, good question, Nick, psychological or behavioral medicine services in your setting in comparison to patients more open to accepting them? Do you have a possible percentage estimate of the two groups? Whoa, okay. My wife's a family doctor. It's very interesting. When patients come to her, they think they have medical problems. When they go to a psychologist, they already know something about the psychological issues. So my success depends on the degree to which I've trained my physicians who see the patients before I do to talk to them about psychological issues, if that's making sense, Nick. So I have trained the residents how to be curious with a patient about, what's your home life like, right? Who do you live with? What are the major stresses in your life? And then if something's really pressing, to be able to say, you know, I want to be the doctor for you in a whole way. You know, and I see this terrible sadness that you have along with your diabetes. And I want to see if we can work on both of those problems. And I have a colleague here down the hall. And sometimes they grab me and they say, would you just come in really quickly to meet this patient? And I'll shake hands and I'll sit down and I'll let them know, like, oh, you know, we can work with you in a collaborative way. I have to say that when I call a patient to schedule an appointment and they say, and where do I go? And I say, just come right back to where you saw your doctor. It's incredibly gratifying. Patients don't fall through the cracks here. They don't get lost. They just come back to their medical home, you might say. So, so there's also this kind of mythology, right, that patients of color or Latino patients or Latino men wouldn't necessarily take advantage of psychological services. And, you know, the response is people will take advantage of psychological services that are respectful and meaningful and culturally and linguistically appropriate. So, Nick, I have a big advantage. I speak Spanish. I meet Spanish-speaking patients, and you know, you can tell I have an accent, but I control the language pretty well. And I already have, through having done my grammar exercises, I'm very lucky because we have a foundation that says, in terms of our rapport, like he's worked hard to try to understand me, I think is the subliminal message. So I think my stats are pretty high. So I'm very patient-centered. You know, psychotherapy isn't for everyone, and not everyone's ready to start. So do I have a possible percentage? I would say that I have at least 3 sessions with 75% of the patients that are referred to me. And I also just want to say that one of the great things about having been here for so long, for 19 years, is that I do some work with a patient, then they go off and live their life, and when they hit a snag or a bump, they come on back, and we're able to meet and do some more work together. It's not a traditional practice. I don't see patients every day, every Monday afternoon, once a week. My schedule's too mad for that. I see patients once or every 2 weeks or once every 3 weeks, or more frequently twice a week if it's a crisis. It's a really different way of working. But I've been very successful in connecting with patients and bringing positive energy, I think, and a lot of optimism and hope. And I have a lot of confidence. I mean, I've seen the power of psychological intervention. You know, when I meet a new patient, I'm already able to imagine them, you know, down the road. And I think that's an important gift too. So hopefully that helps, Nick. Jennifer, looking ahead, what do you anticipate to be some of the obstacles emerging professionals in psychology will have to face in integrating into medical and primary care settings? You know, Jennifer, I think that the obstacles are crashing like the Berlin Wall. This is the new way. This is the way forward. I think that the wind is at your back. The APA has many, many more resources. There is more and more funding. You know, mental health services and parity are on the table. So here's the thing. The obstacles are not on the outside anymore. The obstacles are what we have to manage within. You have to become exquisitely smart and educated in health psychology. You have to be confident. You have to be a good communicator. You have to move fast. If I'm in private practice and I get a referral, you know, maybe I'll call the patient back later that day and we'll schedule next week. When I get a referral for a patient in the hospital, I have to be there like they'll be discharged tomorrow, right? So I have to get to the hospital fast. It's a whole other culture of time. So, Jennifer, you want to spend some time immersed in medical settings. You want to spend time with and talk to people who worked in medical settings. You want to read the books, right, like Bellar's book about, and you want to, you know, so be following again these listservs. So I would say that the barriers are not on the outside. The barriers are just within, and hopefully, you know, I can throw some rocket fuel on your fire to keep moving in this direction. Julie Sherman, I'm also interested in the postdoc programs in primary care, currently a pre-doc intern at Alaska Family Medicine residency. Hey, part of Alaska Psych Internship Consortium. Very nice, great. So that's sounds like a resource. I'm liking this. We're able to share some resources. Donala, by the way, I'm a second-year doctoral clinical psych student. Thank you. Good. Okay. Nice to meet you. Remember those days. Jay, what do you think we as psychologists can do more of to make the case for these types of positions becoming more common? Oh, yeah. Again, you read the data, right? Like, just know the data. Know the data on outcomes and money saving from psychological intervention. Know the data on how many percent of depressed patients have, diabetes patients have depression, and how many post-cardiac MI patients, have depression and suicide. Know the data about, psychological intervention and effectiveness. Be a walking encyclopedia, right? I think that this is the way that we articulate the case. And you don't have to do this alone. This is all data that's, again, accessible. Division 38, again, and 45, amazing resources. But know the resources to do the elevator talk, right? The elevator speech, and being able to articulate why this work is so rich. Hopefully you got some of that from me today, although I didn't give a lot of specific numbers. Sometimes our ability to market ourselves, falls short. Good. So it's so funny. I just got an email from a friend of mine who just heard an inspirational speaker who said, what did he say? He said, promise little and exceed expectations. So, or promise less and exceed expectations. So I don't know if that's helpful or not. I mean, we have to promise a good amount, but if we can exceed expectations, I think that's important. I really spend a lot of time following up, checking in, seeing how the residents are doing, giving them more articles or information related to what they've done. So it's a constant back and forth. Okay, Bai-Yin Chen, UC Davis CAPS has an internship program with behavioral health emphasis. Great. Good to know, thank you. Vanessa, I'm currently an intern at Houston VA Medical Center. We have a primary care mental health integration clinics. Great. A new movement towards integrated care and earlier screening of mental health problems for veterans. Yeah, veterans tend to offer postdocs. That is true. Thank you very much. Good point, Nick. Makes sense. Thanks for the insight. My pleasure, Nick. Very good. Okay. Wow. Really good questions. I love your energy and interest and curiosity. This is really good. It makes me feel hopeful. I feel so hopeful and optimistic about the career. I am happy to answer more of your questions. Let me just give you my ring@usc.edu. If at any point you have a question or a curiosity or anything, you should not feel shy to email me. I'd be happy to think about it or brainstorm with you. I don't know all things, but I might know something that might be helpful or useful. So please don't be shy. Do I work with masters and pre-doc behavioral interns in our clinic setting? I don't, and Julie, it's so crazy. I would love to, but the reason we don't is we have no more physical space in this clinic. We are bursting at the seams. So there's no place even for an intern to sit, which is really sad. So no, I'm always happy to, if someone wants to come by and we can take a little walking tour and I can show them around our clinic. But unfortunately, I don't do any training. Oh, but there's a place, you know where? This isn't, I think it's an internship, but at least it's a postdoc at Glendale Adventist Medical Center in their family medicine residency. It's the program just up the street from us. They do training in, it's working in a primary care clinic. That's in Glendale, just north of LA. So if you're in that area, the guy who works there is Jim Pathman, a buddy of mine, and you might be able to inquire about training opportunities there. I think they do internships. I think they do. Not positive. Okay. Sounds as though you'd be. Oh, thank you, Julie. Well, yeah, I appreciate that. I love what I do, and I'm happy to support and give it away. So, anything else, James?
So,
oh, there you go.
no, I'm still here. I had to unmute myself, but I think we're nearing the time. If anybody else has any other pressing questions, okay, there's a yeah. So I was gonna talk about that. Okay. Yeah, Jennifer, I'm gonna make this available, the recording available, and send it out to members. Just email me and just let me know that you're interested in the presentation, and I can send it your way. It's gonna be a pretty large file because it's a pretty long time that we recorded. But other than that, I think. Oh, there's one more question. Jill has another question, Dr. Ray.
What unique skills and qualifications psychologists have to differentiate themselves from other mental health professionals in primary care? Yeah, that's, I don't really do assessment. I work really closely with my social work colleague, and really we do a lot of the same stuff, except we've been trained in different things. So I know much more about, like motivational interviewing. I know more about mental status exam. I know more, I think, just by the nature of our unique training about geriatrics than she does. We complement each other really well, and we overlap a ton. So it's not so much, the question isn't so much to differentiate ourselves from others, it's being the best psychologist you can be, which is no easy task because our field is huge and we cover so many things, which is also what's so wonderful because we can do so many things. But the question is, how do you be the most outstanding, unique psychologist that you can be? How can you begin to carry with you, sort of like packages of knowledge and expertise and clinical wisdom and experience and confidence that you bring to the work? I mean, I worked in the psychiatric emergency room at UC San Francisco. It was hell. It was so crazy, pinning patients down and tying them, and overdoses, and oh my God, florid psychosis. I'm not afraid of stuff anymore. I'm not afraid. That was an important experience. I don't see those things every day, but when I do, I learned to be calm in the face of fire, right? So there's subtle and sort of unexpected ways that training is important also in terms of that confidence as well. I wanted to just give you one more thing. Let's see, I'm going to type this. If you, wait, I didn't quite type it right. If you Google UCLA Public Health lecture series or something in my name, you'll find a YouTube video or online at their website video that I did where I talk about integrative care and the future of integrated care, and that might be of interest to you as well. So anyway, another reason.
So I think we can end it here, but thanks again everybody for joining us in this very important talk with Dr. Ring. I think Dr. Ring, you did a great job at really resonating the health psychology movement. And then that's one of the experiences that I've had in my doctoral program, health psychology, as being part of the integrative care kind of model. But so I really appreciated, having this conversation, hour and a half with a lot of the Division 45 members and others. But thank you, Dr. Ring.
My pleasure. Thank you all for hanging out.
Yeah, thank you. And members, attendees, if you're not already a member of Division 45 of APA, I would encourage you to sign up. Same thing with Division 38. Very resourceful. Both are very resourceful divisions of the American Psychological Association. For Division 45, what I can speak to that is that I am going to plan to do a lot more or host a lot more of these seminars, and I hope Dr. Ring comes back for another seminar. But yeah, I encourage you to kind of stay tuned. Other than that, that's pretty much it. Thank you, Dr. Ring. And thank you, everybody.
My pleasure. All right.
Thank you.
Take care.
Take care. Thank you. Thank you. Bye.